The most common argument against single-payer is that it will raise your taxes. That argument is technically accurate and deliberately incomplete. The full question isn't whether taxes would increase. It's whether taxes would increase by more or less than everything they replace. This part does the full accounting. Let's start with what Americans are currently paying. Average annual premium for family employer coverage in 2025, $26,993. The worker's share of that, $6,850 per year. Average family of 4 total health care cost, including out-of-pocket expenses, $32,066 in 2024. Family premiums have increased 26% over 5 years, outpacing inflation. Employer health care costs are projected to exceed $17,000 per employee in 2026, a 9.5% jump from 2025. This is what you're paying before single-payer enters the conversation. Now, here is the Sanders financing math. Under the Medicare for All Act's 4% income-based premium, a family earning $50,000 per year pays $844 annually. That family is currently contributing $6,800 toward employer family coverage, before deductibles, copays, or out-of-pocket costs. Citizens for Tax Justice ran the full analysis. Middle-class families would see after-tax income increase by approximately $3,200 per year. The Rand and JAMA study on financing found that the lowest income households go from spending 27% of compensation on health care to 15%. The highest income households go from 27% to 31%. The objection is legitimate when applied to the highest earners, for whom the tax increase may genuinely exceed current costs. It's misleading as a general claim without the full comparison. Now let's add the pieces most people don't see. Administrative waste. The Congressional Budget Office estimates that single-payer would reduce administrative costs by approximately $500 billion annually. That is the cost of running hundreds of competing insurance systems with different billing rules, different coverage standards, different prior authorization processes. Taiwan's single-payer system operates with administrative overhead of just 1.07% of total program expenditures. The American multi-payer system consumes between 1/4 and 1/3 of every healthcare dollar on administration. $500 billion a year, not on care, on paperwork. Wages. The Federal Reserve Bank of New York published research in March 2026 finding that rising employer health care costs suppressed wage growth by approximately 1 percentage point per year. Among businesses that saw insurance costs rise, average wage increases were 3.8%. If health care costs had held steady, those firms' estimated increases would have averaged 4.7%. The money your employer spent on premiums is money that did not go into your paycheck. The Federal Reserve documented this. Drug prices. Rand Corporation research found that U.S. drug prices averaged 2.78 times higher than in comparable countries. For insulin specifically, a drug that has existed for over a century, the average U.S. manufacturer price is $98.70. The OECD comparable country average, $8.81. The same insulin, 11 times the price. Under single-payer, the government negotiates drug prices as the sole buyer for the entire country. This is what every other country already does. The price difference is the documented cost of the current prohibition on that negotiation. Medical bankruptcy. Medical bills contribute to roughly 2/3 of all personal bankruptcies in the United States. 100 million Americans owe a combined $220 billion in medical debt, according to the Consumer Financial Protection Bureau. 36% of U.S. households carried medical debt in 2024. Medical bankruptcy doesn't exist as a meaningful phenomenon in Germany, Taiwan, Australia, or France. It is exclusively a feature of systems that treat healthcare as a commodity rather than as a service. Surprise billing. 4 in 10 insured non-elderly adults received an unexpected medical bill in the past 12 months. 2/3 of Americans are very or somewhat worried about being unable to afford unexpected medical bills, despite most of them having insurance. Only 20% of consumers always know what they will owe before receiving care. Under single payer, no networks, no out-of-network providers, no surprise bills. Every licensed participating provider is covered. You receive care. Medicare pays. The tax argument, restated with the full ledger. Taxes go up. Premiums disappear. Deductibles disappear. Co-pays disappear. Out-of-pocket maximums disappear. Surprise bills disappear. Medical bankruptcy disappears. And $500 billion in annual administrative waste gets redirected toward actual care. For most working American families, that math runs strongly positive. In Part 3, we examine the objections that have prevented this conversation from advancing, and we measure each of them against the evidence.